So I'm the guy before lunch. So I see this as being part entertainment, part science fiction. Although most of what I say, in fact everything what I say, we can do now in Brisbane. So I'm going to talk about a lot of new tests and some neurobiology. We can now do all of this, and I'll explain that as we go. The key thing I want to talk about is this little nosology, type 1 versus type 2 trauma. I want to tell you about that because it revolutionised my clinical career and actually kind of systemically my managerial career as well. And it's from Lenore Ter, T-E-R-R, Lenore Ter. Anything written by Lenore is worth reading. So we're going to go into type 1 and type 2 trauma. Maybe just a little bit about myself, and by the way, we need some water if I'm going to yell at you. A little bit about myself. I'm a child and adolescent psychiatrist. I run a service which people in Tassie would be fairly envious of. I have 290 clinicians that actually work for me, and we have inpatient day program. We have 4 community clinics. We have an infant team, a research team, a juvenile justice team, a drug and alcohol team. We're a big service. I know that we're incredibly privileged in that, and that's bad luck for you, but good luck for me. Anyway, and we see about 6,000 kids a year, about 50 to 80,000 occasions of care a year. And I've been running it for 10 years. I used to have hair, but I don't anymore. So what I'm going to talk about is just briefly about Marion and Ilse. These are not obviously real people. And this whole idea of type 1 versus type 2 trauma, I'm going to tell you about developmental psychopathology in 20 minutes. That's all you need to know, all right? We'll just knock that off. And then just kind of applying these developmental constructs, add in some family and parenting. I might tell you a little bit about what I think this should inform about child-friendly cities, but we mightn't have time for that. If we don't have time for that, I'll come and harangue people this afternoon. Okay, so Marion, again, it's not a real name, 14-year-old, living in a residential setting, NGO, not really attending school, little contact with family, into care at age 8, prior single-parent family, lots of concerns about mum's substance abuse and possible neglect. More recently, concerns about sexual abuse and domestic violence. Sporadic contact with mum and siblings. Every time she gets a phone call, she gets really dysregulated and, her mood kind of gets a little bit off and her behaviour kind of goes off. She self-harms. She turns up to accident and emergency, usually by the police, under what we call an emergency examination order, an EEO, and she's been seriously cutting. And she does pretty spectacular things. So this is a picture of plain abdomen picture. By the way, what's that? There's a little clue here. That little line there is the clue. Yeah, that's where you put your thumb in a pocket knife and lift it up. So she's actually undone a whole Swiss Army knife and swallowed it, okay? This is a good effort. When I met her pre-operatively, I went into theatre with the, because she trusted me when she was being put to sleep if I was there. I said, gee, sport, this is impressive stuff, you know. Not a lot of people could achieve this. Anyway, lots of suicidal thinking, deliberate self-harm, aggression to staff, aggression to others. You've probably heard lots of stories like that. Okay, Ilse, 14 years of age, living at home, single parent family. She goes to school, some bullying at school, but pretty well managed. Involved in a serious motor vehicle accident. Passenger in the other car died. She needed to go to hospital overnight, but to exclude a serious injury. Her mother had a serious head injury, and in fact, mum's function declined over the next 6 months. This kid had to go into care while we found some people around Australia who were kin to look after her. Ilse had symptoms and went under and had this kind of personality change and went into care. So they're both kids in care. But they're both fundamentally different, and their outcomes and prognosis is overwhelmingly different. And the next 40 minutes I'll tell you why, okay? So, a bit about developmental psychopathology. This is my view of life, all right? This is the sort of the little kind of overarching heuristic of life. And what it is in the fetal period, you go up incredibly quickly. You develop competency amazingly fast in infancy. And then you kind of go up slowly. My 3 teenagers feel that at my age you fall off quickly here. Apart from here, I don't think there's any evidence of that, but you know, we all have our own perspectives. These are confidence intervals to remind me that life is an incredibly broad church. If you think that your reality is similar to anyone else's, you'll pathologise everybody. Okay, life's incredibly broad. I was a Navy doctor years ago, and I remember the Admiral moved us close to a New Zealand ship, and then he started hitting golf balls at it, and they were all diving for cover. This was normal behaviour in the Navy, right? I thought it was kind of aggravated assault, but you know. Life's a very broad church, and at any point in this kind of heuristic, you can divide it in some biology, some cognition, peer stuff, family and school stuff. And in fact, with one of these developmental curves, you can describe almost every condition in child and youth mental health. So this first one's a developmental curve of a kid who's left development really early in life. They're still developing, but they're dancing their own tune. They're under the normal curve. They're less competent in many aspects than most people, but they're still developing. By the way, I like people to heckle. Does anyone know what condition that kind of is? What condition they're developing, but they're always under the normal curve? Sorry? Yeah, developmental delay, intellectual disability, autism. The autistic kid is still developing. Okay, they can do much more things when they're older than younger, but they're kind of under the curve. This one's an interesting one. Normal, 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 normal. Bit of a kind of a prodrome. Something's going on here. They're kind of falling off the normal curve a little bit, and then they suddenly get unwell. And they might have a variable outcome. Do you know what curve that is? Could be type 1 trauma. Has someone been to one of my talks before? No, it's not. Let's not talk about trauma yet. Apart from trauma, what's that?
Mental health.
Who said that? What type of mental health? That's a classic picture.
Well, you're an adolescent,
Yeah. That's the classic picture of early onset schizophrenia, by the way. That's the classic picture of early onset psychosis, where the little munchkin goes into their bedroom, usually when 16, 15, 17, stays in their room, gets very interested in things, often Eastern religion or something mystical or something kind of cosmic, and then after a while develops delusions and hallucinations. Okay, it's a classic picture of early onset psychosis. So almost every condition in child and youth mental health you can describe by one of these interesting developmental curves. Well, let's unpick the model a little bit. So here's the fetal period. Increasingly, we're just, from a biological point of view, we've always been interested from an attachment point of view, but from a biological point of view, we're increasingly fascinated about this period. Now, at the end of the fetal period, in the last 2 months of life, if you're making connections, if you're making synapses in your brain, how long does it take an infant in the utero to make 40,000 connections? Someone yell out a number. How long does it take? So 40,000 connections is like twice the number of Aurora Stadium if you completely fill it. How long does it make for those people to shake hands with each other? 1 second. Someone has been to one of my lectures before. It takes 1 second. 1 second to make 40,000 connections. Okay? Just get your head around that. That means you have to not only shake this person's hand, you actually shake 40,000 people's hands in 1 second. That happens for 2 months before you're born and about 2 months after. Exactly the time where the mother or father is holding the baby at their focal length. So I can't have children anymore because my focal length is too far. And they're doing things a baby likes, they're opening their eyes and they're talking with a nice high voice and they're going, Okay, exactly the time of intersubjectivity. Exactly that time. You're making 40,000 connections per second. It's where, and I say this to his face, I don't like stabbing people in the back. This is where Pat McGorry is completely wrong about where we should be investing in mental health. We shouldn't be investing in adolescence. We should be investing relentlessly here. If you want to destroy the life of a human being, you destroy it in the first 3 years in pregnancy and the first 3 years of life when you are making connections. All right? Very important. Other things going on, toxins, drugs, alcohol. We now know there's a lot of people with fetal alcohol syndrome. It's not all or nothing, it's a continuum. Okay? We now know a lot of stuff about that. We know that early birth weight is a problem. A couple of us years ago looked at the West Australian Child Health Survey and married it up with the midwife's notifications, and we found that 11 years later, if you were small for dates, your aggression was 5 times the average 11 years later if you were small for dates. 11 years later, you were hyperactive or withdrawn 7 times if you were small for dates.
What do you mean by small for dates?
If you were born, it's not when you were born, it's if you are the birth weight that's correct for that age. So if you're born prematurely, but your birth weight is right for that age, it's fine. If you're born at term, but you're underweight, you have intrauterine growth retardation, and it has profound implications. Okay? Very interesting. 11 years later. So now, by the way, we can predict your blood pressure as a 50-year-old by things inside your womb when you were a baby. Okay? So the fetal period is actually the most time in your life to neuroprotect. And this is actually a slide of what actually happens. This is a process called apoptosis. Don't try to remember that, but this is at birth, and then you incredibly arborize your brain, and then later on you kind of organize it, and if you don't use it, you lose it. And if you use it a lot, you probably have more connections and stronger in that area. I'll show you some slides later about this. But this mainly doesn't happen at 14. This mainly happens early in life, where you're making connections and you're forming the basis, the neurological basis for the rest of your existence. And there's lots and lots of evidence about this. If you're really into this, just Google Rutter, Sir Michael Rutter, and Romania, and you'll find all those really disturbing researches about his group that looked at Romanian orphans. Now, you remember, well, some people don't remember. I remember when the Berlin Wall came down and all those countries fell over one after the other, and they found kids in Romanian orphanages, and the care ratio was 30 babies to 1 carer. 30 babies to 1. And these kids had 2 issues. They had lack of stimulation and profound emotional neglect, but also malnutrition. What you find is their IQ was completely correlated with how long that they'd been babies in the orphanage. If you were a baby in the orphanage for 40 months, your IQ was profoundly lower. If you were adopted straight away, your IQ was about the same as the normal population. So the length of time of neglect in those first few months is profound. So when I'm interviewing 14-year-old Marion or Ilsa, I have in my head, I'm interested in the fetal period, I'm interested in the child period, in the infant period, sorry. Obviously attachment, security, parental intuitiveness and parental reciprocity. I thought we saw some wonderful demonstrations of lack of reciprocity when Wendy was demonstrated that she was kind of scared than the infant, you know, that was fantastic. I know you're doing that rhetorically. It's a beautiful demo. But also, we now know some fascinating things about DNA. So this used to be the central dogma of DNA. So there's your DNA. DNA transcribes RNA, which is the messenger system, which goes out into your body and tells the protein factories to work. That's it. Simple as. DNA talks to RNA, talks to protein, makes protein, okay? This has been there since Watson and Crick. We now know it's completely wrong, okay? This is really, really, really fascinating. So, there's a guy called Michael Meaney, which we all hope will get the Nobel Prize. Michael Meaney looked at rats. So just don't look at that for a minute, I'll just explain it. Michael Meaney looked at little rat mums, and you can breed the little rats so they're genetically identical. And then what you do is you breed together all the ones who are kind of slightly better parents and all the ones who are slightly not as good parents, okay? Until after about 15 generations, you have genetically identical good mums and genetically identical not very good mums. It's very easy to do. And you can tell a good mum rat who will roll her body over and expose her teats to the little pups so they can drink milk, and will share warmth with them, and if they're crawling away, she'll actually circle them and make sure they're safe. And if they crawl away, she'll go with them. It's just good attachment. The not so good mum rat will roll on the babies, roll on them, not present her teats to drink, won't give us stuff if they walk away, won't share warmth. It's a very good model, okay? Now the really interesting thing is that good parenting, they also lick and groom, good mums lick and groom their little babies. The really interesting thing is now we know that good parenting makes the genes work faster. Okay, this is really interesting. And I can just, my friend and colleague Matt Sanders in Triple P is going, I told you so, okay? And all these parenting programs. Good parenting makes your genes work faster and better. So for instance, these little rat babies had more glucocorticoid expression, they had more receptors, they had more this neuronal growth factor 1, and they had a better biological response to stress. Okay? So they had a modulated, nice response to stress, not this all or nothing response to stress. Now we know that good parenting makes your genes work better. And in fact, we know how. This is just in the last couple of years. We now know why. So if you look at DNA, DNA just doesn't look like a string. It looks like a series of beads. So there's these kind of bead things. And the bead is actually incredibly ravelled DNA that's really tightly ravelled. Okay? And you can imagine if I'm a little bit of RNA and I want to read that code, it would be very hard to read that. That's incredibly ravelled DNA. But reading that unravelled bit would be really easy. That bit's just floating out there in the wind. Reading that's easy. Now these histone proteins, what happened, good parenting changes those yellow bits and causes your DNA to be unravelled so it works faster and it works better. And we know that parenting causes your DNA to be unravelled. This is really interesting. Some of the scary stuff, this is called the gene programming. It used to be called the gene programming theory, but now it's been proved again and again and again. It's probably not a theory anymore. This is why some magistrates are now seeing the third generation of a family. You know, the magistrates sentence the grandfather, sentence the father, sentence the son, because this is actually inherited. Your degree of ravelling is inherited. You pass this through your generations. You pass it biologically, but also, unfortunately, you pass it environmentally because you pass on, you model parenting to the next generation. Okay, so not only do you get it biologically, you get the reason for it in the first place, which is problematic parenting. Of course, there's a whole bunch of drug companies running around at the moment really trying to change that protein, which is interesting and actually might be useful. So you get it? Okay, unravelling DNA through parenting. genes we now know we can make genes work faster. The other bit of science fiction is this, so I'll just explain this. Do we have any Kiwis in the room? Come on, fess up. See, in Brisbane there'd be 30%. Any Kiwis? One. Come on, there's more than two? More than two? Okay. In 2005, probably the most influential paper in behavioural genetics was published. It was published from Dunedin in New Zealand. This is an amazing bit of work. So we'll just go through this. And if you're really keen to read it, I mean, I wouldn't. I'd just trust me. But if you're really keen to read it, the person's name is Caspi. Absalom Caspi. Now, this is the Dunedin multi-dimensional study of childhood, and they looked at 1,096, 1,090, see, I'm thinking New Zealand, I said that. Did you see that? That was interesting, wasn't it? That was interesting. 1,096 children, and they saw them every 2 years, all right? Every 2 years, and they're now about 30. And the data was on the computers of Terry Moffat, and Terry did one of her amazing things. She did many amazing things, but one really clever thing was she married Absalom Caspi, who was a geneticist. And one morning, I'm sure they're sitting there over breakfast saying, let's go back and genotype everybody. Let's go back and get their genes, okay? Because they'd never done that before. So this is the genes of everybody in the multidisciplinary study in Dunedin. And they're focusing on the serotonin gene, which we know has something to do with depression. And here's your probability of depression going up. A probability of 1 means it will definitely happen. That's it. 1, it'll happen. It's unitary. A probability of 0.7 is really high. So this is the probability of depression at age 26. And down the bottom here is we have if a judge in a court of law said you were severely maltreated, probably maltreated, or had no maltreatment. Now, there's two types of the gene, and I don't think geneticists are known for their creativity because there's an S and an L form. S stands for short, and L stands for long. That's it. Because you've got 2 chromosomes, you can have 2 S's. That's 2 S's. 2 L's or 1 of each. That's it. Now, look at this. This is really interesting. I hope you guys can see over here. If you are LL, you've got 2 L's, 2 long forms, your depression does not change over the first 26 years of your life, even if you are severely maltreated. You are biologically resilient to depression. You got it? These people need to join the SAS or the ambulance service or run a large child and youth mental health service. Okay, look at that. Look at that. If you have 1 of each, you're a bit in the middle, but look at the poor old SSs. If you are genetically SS, you have a huge chance of depression, okay, by the age of 26. Now, this in no sense is biology winning the nature-nurture thing. In fact, this kills off the whole debate. If you get involved in a nature versus nurture debate, you're just kind of, you're behind the times, folks, okay? Because look, if we fix nature, if we fix nurture, if there's no maltreatment, it doesn't give a toss what genes you are. If we follow, the advice of Dorothy and others and have this big public health approach and do all sorts of great things we can do, if you have no maltreatment, it does not matter. But if your environment is incredibly adverse, it does matter. It only matters in environmental adversity. Okay? Now, if I was in 1939 Germany, I might think of getting rid of those SSs. because they're clearly going to be a burden on our society. Why should we not get rid of SSs, apart from the fact that I might be one? Why shouldn't we get rid of SSs? No, I think LLs were in charge at the time. Well, on the Beyond Blue board, I'm very lucky I'm a director of Beyond Blue. And because I'm a McDermott, I sit beside Gary McDonald, Norman Gunston. Most of the most interesting people on the planet are probably SS. Kurt Cobain and John Lennon and, Jackson Pollock and, they're all probably SSs. I've told Gary I want a hair. He keeps saying I don't have much. But this is, they're actually probably some of the most interesting punters out there. Now, this is called a G times E, gene times environment interaction. Really interesting, G times E. It's not your gene, it's not your environment, it's the interaction of the two. And we can find it for all sorts of things now. This is just this little burgeoning area of research. This is whether you're a psychopath or not. And my eldest daughter currently is in love. It's really interesting seeing a daughter who's in love. And I've told her and her boyfriend that I'm going to take one of his hairs because I want to know. I want to know if he's a psychopath, all right? The bad news for him is he's got flaming red hair, so it's easy to find. They're everywhere. So this is the gene-environment interaction for psychopathy. This is a different scale. This is units of Z-scores. Who cares? Basically, if you've got a low monoamine oxidase, you're much, much more likely in the face of adversity to be a psychopath. Again, no adversity, who cares? Doesn't matter at all. Doesn't matter at all. But if you have adversity, you're much more likely. And now we're seeing lots of these. There's actually the relationship between psychosis and marijuana is a COMT gene. There's a gene called, well, you don't need to know, it's called COMT. And there's two forms. And again, the temptation to take a hair of one of my kids is very strong. But the problem is the ethics hasn't caught up, because if they're the low vulnerability COMT, what do I say? Smoke as much as you like. I don't think so. So this is interesting. So this is gene-environment interactions. So we've done, when I stopped playing, we've done some fetal stuff, which I'm really interested in. We've done some infant stuff. Clearly, I'm fascinated about what's going on in their childhood. I suppose the interesting about childhood is when I'm assessing a child, they're in a slightly more kind of, difficult laboratory. I mean, school's harder than home. High school's much harder than primary school. They're in this kind of little laboratory, and they're showing how they deal with the normal adversities of that environment. And because part of the subcontext of this talk is biology, we now know in this period that there are some truly frightening things coming from neurobiology. So this is actually a friend of mine called Akemi Tamada, who's in Japan. She's just this amazing quiet achiever. She's doing MRIs with young women over the age of 18 who can give consent. And of course, an MRI is no radiation. It's not dangerous in any way. It's scary and noisy, but it's an ethical thing to do. And look at this. 18% reduction in the visual cortex of girls of abused young women who experienced abuse during childhood. That's like 1/5 of the seeing part of your brain is actually not there. Okay? Now, I talk to a lot of politicians, and it's kind of funny. We have a professional thing here. Social workers can talk to one slide for 40 minutes. It's fantastic. I can't do that. When I'm on medication I can, but I can't do that. I don't talk to politicians anymore. I show them this slide. That's all I do. I sit there quietly, letting the tension build, because people hate silence. I'm a psychiatrist, I can do silence. And I say, listen, sunshine, what the fuck are you doing about this? You know? We're looking at 20% reduction in visual cortex in abused girls, right? Gets worse. This is the hippocampus. The hippocampus is part of, I suppose, in that kind of reptilian model, it's not neocortex, it's not new, but it's not really old, it's kind of mid-development. And the hippocampus is the emotional processing part of the brain. Okay, it gets a lot of afferents from eyes and ears and taste and other things. Interesting, a lot of taste, by the way, because that's very old. Obviously visual cortex, and it kind of integrates stuff and puts out a general tone, your general kind of emotional tone. Okay, reduced volume in the hippocampus if abused at age 4. Look at that, right down there, that's age 4. Incredibly significant. Interestingly, and this is where Pat might be right, Pat McGorry, abuse in early adolescence is also highly problematic. This seems to be a critical period for abuse of the hippocampus. Around the age of 3 to 5 is a time where you seem to be, a major task is actually learning how to regulate. And I think that's true. My kind of hanging around in shopping centres, which in Queensland we have a blue card so you don't get arrested. I'm allowed to hang around shopping centres. If you watch little kids, okay, it's a time when they're kind of learning to regulate. No, you can't have that. No, we do fun shopping at the end of the other shopping. We'll come back for that, but we do the proper shopping first. You know, they're learning to regulate. It seems like that's a real critical period. It just goes on and on. Reduced prefrontal cortex grey matter in young adults exposed to harsh corporal punishment. One of the interesting things about this is different areas of the brain are affected by different types of abusive situation. Okay? So this is harsh corporal punishment, and the frontal cortex is about executive decision making. Okay, so early sexual abuse, emotional tone and emotional regulation. Sexual abuse about something about vision, which we all haven't quite worked out yet. But I see a lot of sexually abused girls who are hypervigilant, as if they're sort of a little bit blind, and maybe they are a little bit blind. It's a really interesting hypothesis. But harsh corporal punishment, problems with executive functioning, and it just goes on and on and on. This is white matter tracks. It just goes on and on and on. Lots of now, we're in this kind of amazing neurobiology revolution, and lots of data coming out about the effects of these kids. Their brains are different. That's the sad fact. One thing we're really interested in, this kind of international consortium, we're really interested in is there is a small bunch of these kids who go through incredible adversity. They just go through Armageddon, but they turn out all right. What is that all about? And I think that's about they have protective genes. Remember LL versus LSS? I think some kids are lucky, they have a constellation of protective genes, all meet Pop, Granddad, that one person who helps them regulate, that epigenetic stuff helps them regulate their genes and make their genes work faster. All right, adolescence. When do I stop, by the way? When do I go on to? Excellent. Adolescence. Just some fun stuff about adolescence. Don't forget that adolescence is a construction of the West. Adolescence doesn't exist in most cultures. Okay? We do things to prolong adolescence, like going to medical school. Okay? If you read Dickens, and everyone should read Dickens once, there was no adolescence. 14, you went down the mine, that was it. Adolescence is our own, you know, if anyone whinges about adolescence, we constructed this. We created this. Personally, I love the little munchkins, and they know it. I get on really well with adolescents. Look at this. These are t-shirts. Keep music evil. I just love this. We're doomed. I just love these t-shirts. Anyway, there's a whole bunch of tasks of adolescence about getting mastery of mood and behaviour, impulsivity and gratification in a more socially demanding social frame. The importance about adolescence is incrementally it's a harder laboratory. In primary school, if you didn't bring your lunch, someone will give you lunch. Okay, in my high school, you know, the older boys in my high school had beards. I mean, for God's sake. You know, if you didn't bring lunch, they'd say something very rude. Obviously, individual separation is a major task of adolescence. The other interesting thing about adolescence is a time of the onset of a lot of adult mental health. So for instance, this is a graph of depression, and the B line is depression in girls. Before puberty, the rate of depression in boys and girls is about the same. Okay, before the age of 12, it's about the same. And then girls take off earlier and are always higher across the lifespan. My female patients say that's because they have to deal with boys who it happens later and they never are high. Don't forget, if I drew that graph for behaviour problems, it'd be exactly the same, just opposite. These are kind of gender-based ways of dealing with dysphoria, really. Just building up this model, so we have fetal, infant, child, adolescent. There is always parental influence across your lifespan. Even if you get to my age, there is still parental influence. If you don't believe me, go to your brother or sister's house and look for the sugar. It's exactly where your mother puts it, and it's where you put it. It's frightening. It's just frightening, you know? I remember my son said, "Look, Dad, grandmother irons just the way you do." And I said, "And God forbid one day you might learn to iron too." So you have these persisting biological effects. Now, I've drawn them this way because they're persisting across the lifespan. And again, the way to understand this is you must go to a 30th school reunion. If you're asked, you must go, okay? It's fascinating. The quiet ones are still quiet. The noisy ones are really noisy. The ones that wouldn't come to parties didn't come to the reunion, you know? It's really fascinating. People, they might dress better, but they don't change. It's really interesting. All right, so building this model, this is all embedded in family resources and obviously culture. And culture, unfortunately, in family resources is important. Unfortunately, there is a strong socioeconomic gradient. So for instance, in whatever this is actually a British study. We don't particularly talk about classes, but if you're in social class 5, you've got a 3 times increased rate of sudden infant death syndrome. You've got a much greater rate of injury. You've got a much greater rate of almost everything. Unfortunately, there is a social stratification, which is very sad. Now, this is a fascinating study, and this gets back to some neurobiology. This study is called, incredibly frightening name, it's called The Everyday Experience of American Children. Okay, that's the name of the study. It scares the hell out of me. What they did, before Big Brother, they put microphones in houses and they randomly turned them on and off. Over 4 years. It's pretty cool. They just turned these microphones on and off. Now, these are their terms, not my terms. Look at the number of words a 4-year-old hears. In a professional family, that 4-year-old will hear, their temporal lobe will hear 50 million words. If you're in a welfare family, they'll hear about 15 million words. Later on in a private school, this teacher can almost give a 4-part instruction with the expectation the child will get it. If you give a 4-part instruction to this kid, you are just fooling yourself. You give a 1-part instruction because their temporal lobe is fundamentally different. And I saw in the paper this morning, because I'm a well-informed kind of guy, that there's a voluntary scheme in Hobart to talk to children. What a profoundly good idea. A profoundly good idea. When we all retire, we just all need to go and talk to, get blue cards and, do it in an organised way and read Harry Potter to kids, all right? It's incredibly important because this is about temporal lobes. Look at encouragements. Professional families encourage. They get like 700,000 encouragements. Some of these welfare kids have no idea what an encouragement is. If you encourage one of these kids, it's kind of like, what do you want? No, I don't want anything. I'm just telling you you're a great kid. No, what do you want? Okay, they don't have that kind of understanding. By the way, discouragements are very similar because, again, you know, when my little kid got near the road, I was very discouraging, so that's pretty similar. Social class, this is also important. If you want to adopt yourself out, make sure you adopt yourself into a high social class family. Your IQ will go up. All right. It's true. It'll go up profoundly, okay? Okay, let's put it all together because actually, remember I wanted to talk to you about type 1 and type 2 trauma, so we'll just put it all together. So there's actually, in your day-to-day practice, there's two types of trauma. There's type 1 and type 2. So this is type 1. So the person's coming along, normal, 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 normal. Something catastrophic and singular has happened. So what's some examples of catastrophic singular things? A car accident's a classic one. You've been driving along the same way for 5 years and you've been wiped out one morning. What else? Okay. They're fantastic examples because they're both right and wrong. Okay. Some people think divorce is a type 1 trauma. My experience clinically is there's sometimes 2 or 3 years of ugliness before and 2 or 3 years of ugliness after. That's not a type 1 trauma. Death might be a type 1 trauma, but if it's after 7 years of dying from cancer, it's not a type 1 trauma, but it can be. I mean, the classic one is the poor university student who walks across the campus every night for 3 years and one night is raped. That is a type 1 trauma. Those people, I say, I will get you better in 3 months. In my most professorial kind of voice. I will get you better in 3 months. Because you'll still have a scar, but you'll be functioning okay. Because this kid's had 14 years of completely normal development. The genes are normal, their gene functioning is normal, their environment's normal, everything's normal. But look at this person, this is type 2 trauma. It starts earlier in life, they have multiple traumatic events, and they're under the normal curve for a long time. The mathematicians in the room will know that the area under that curve is huge when you're supposed to be organising your brain and developing. That is the classic type 2 trauma. I'm skipping on, folks, because I've obviously talked this is all really interesting, by the way. But you didn't get to hear it. But I'm happy to leave the slides here. Type 2 trauma and parenting. So this is one of those two kids. This is biological parent. They were with him for a while. Foster parent 1, foster parent 2, foster parent 3. A magistrate, you know, did that. 4, 5, 6. Foster parent 7, 8, 9. A lot of kids in our service have 11 or 12 placements, you know, 14 schools. We published a paper on this, you know, it's really highly problematic. They have particular type 2 syndromes. So often these kids have low-grade, long-standing depression. It's called dysthymia because you can charge more money for that. Bulimia. Unfortunately, about 60% of people with bulimia actually have trauma histories. Substance abuse. Lack of regulation in that type 2. Remember, early on, you're there to regulate these kind of major biobehavioural systems like mood and attention, self-care. So lack of regulation causes things like, this is an old Freudian term, which I just love, ego deficiency. Ego deficiency means you don't see things through. You might stay in 5 towns for 4 months. You might have 8 girlfriends or 8 boyfriends for 4 weeks. You might start 5 university courses for 1 term. If I've described anyone in the room, come and see me later, all right? But this is classic not being able to see things through. You might have relationship difficulties. There might be all or nothing. I remember I was working in Perth and a patient of mine told everybody I was the best therapist in Perth, which was arguably true. However, However, I was 15 minutes late and they referred me to the Medical Board of Western Australia. Fantastic. It's diagnostic. So it's all or nothing. Relationships are magnificent or they're catastrophically attacking and punitive. Issues with impulsivity, self-harm. Sometimes you feel so dysphoric that you have to cut yourself to actually feel real and see blood flowing. Oh, by the way, this is our type 1 girl before, type 2 girl. She's done something. Can anyone see what she's done? Ah, you've got it. Good work. She's got something up here. She's actually undone a wrench, bent it in half and swallowed it, and had a respiratory arrest. She lived. I wasn't... That even tested my kind of, compassion, and I'm saying, well, I said before you were pretty good at this, but this is going a bit far. And of course my job is to make sure the surgeons treat her properly because they're pretty angry about this. Now, the implications of type 1 and type 2 trauma are really important. So for instance, the first thing is you need to actually know what you're dealing with. If you don't know what you're dealing with, you're going to do the wrong thing. Type 2, I never think cure. I just don't think cure. I think I need to be with you for probably 2 or 3 years to try to inflect your trajectory up a little bit so in 4 or 5 years' time you'll be functioning better. Okay? Type 1, I might think, damn it, we're going to go for cure. We're going to go for complete symptom absence. We're going to go for back to normal. Type 2, you'd never do that. It's got implications for knowing what you're dealing with. If you know someone who's got type 2, then they're probably going to be very up and down. They're probably often going to be suicidal. They might be aggressive. They're going to make poor decision making. As a generalisation, as a big, big generalisation, relationships are going to be on and off a bit. And they might have some specific symptoms. So arming yourself with this is actually very helpful. They're incredibly off and agitated and aggressive one day. It's got nothing to do with you. It's actually part of the presentation. It's completely kind of normal. They also have a different suicide kind of risk assessment. So a lot of people, in terms of suicide assessment, look at the incident, look what happened, look about the self-harm, look about the circumstances around the cutting. But with type 2, they also have this huge cumulative risk because they're much less dysregulated. And when they need those resources that stop them doing something, a lot of these folks don't have those resources, okay? Whereas the rest of us kind of do. So there's kind of therapy implications, and we're just going to finish with these last 2 slides. There's therapy implications with type 2. It's actually, and this is getting back to something that Wendy talked about very nicely about, it's actually all about relationships. The good news is this is not very technical, this is not very clever. Type 2 is actually about relationships. And in my service, you're allowed to see these kids for 2 or 3 years. That's it. None of this 6-session rubbish. Okay, that's just rubbish. Okay? You're not allowed to see 20 of them because I think you'll burn out and do architecture. But you're allowed to see 3 or 4, there's no money in architecture. You can have 3 to 5 of these kids, but you're allowed to see them for 3-5 years, I don't care. Relationship, relationship, relationship. Boundaries, boundaries, boundaries. Boundaries, boundaries. I can't tell you this more about this. Motivation to change. Motivation, not so much to change, but motivation that change is possible. Okay, lifting horizons to things. I try to see these punters when they're well. They say, I'm doing really well. Why do I need to come and see you? It's just this funny idea I've got. I don't want to see people in serial crisis. You can't cause profound change in crisis. These folks will learn new skills and adaptations when they're well, not when they're in crisis. Okay, so see them when they're well. I mean, see them when they're in crisis, but don't expect to do anything. Be very slow to intervene with symptoms. And again, Wendy's point, Be very slow to intervene with defence mechanisms. Okay, if I dissociate, I was talking to another psychiatrist. I sat beside a psychiatrist on a plane, which is really dumb. This guy wanted to talk about crashes. And I said, listen, mate, there's one rule here. There's one rule here. If we go down, I plan to dissociate, and your job is to leave me alone. Okay? That's it. Okay? If I'm defended on the way down, you just leave me alone. I don't want to hear any of this kind of reflective stuff. I don't want to hear any of this interpretive stuff. You deal with it yourself. So be very slow to open a Pandora's box, especially if you work in a service that only sees kids briefly. If you work in one of these 6-week, 3-month, 6-month services, you can't open that box. You don't have to. You're not around to. It's unethical. You don't have time to close it. You don't have time to help them deal with all that stuff. So don't do it. And this is Dorothy's very lovely point about being systemically aware. I love family therapy. I don't do much of it anymore, but every inter-organisational, interprofessional, kind of service issue I do a family, usually firstly a structural assessment in a family therapy frame, and then a systemic assessment, because it usually tells me what's going on. Understanding, if you ever get a chance to do a bit of family therapy, it's just a wonderful thing to do to understand the world. If you want to understand in-laws and stuff like that, it's very helpful, okay, very helpful. Family therapy. And this is what it looks like, they're kind of well, they're in crisis, they're kind of well, they're in crisis. This is kind of fairly typical. This is fairly typical. I'm a very overpaid case manager. Case management is good. I know where all the refuges are in my area. I know where all those things are, I get paid 4 times more than anyone else to know that, but I don't care. I'm quite happy with that. But this is kind of good. Supportive psychotherapy is what we do. Brief periods of crisis counselling. And occasionally when they're really well, we might work on specific tasks. And although, in fact, a friend of mine and I wrote a book on trauma-focused CBT, we try not to do it with this population. I often put that, do you want to do that in year 12? Why don't you do it next year? We kind of put people off. Was that a 5-minute tinkle?
It was.
Or was it an ending tinkle?
No, it was 5.
Thank you. So, specific task, yeah, okay, a little bit. Anticipate a long investment of time. And don't forget that one of the most profound things you can do is be modelled as a relationship of, you might be, the one adult that actually hasn't tried to exploit them or has just been there for them, and that's actually a very, very good thing to do. I put in some slides about that, but I'm not going to do that. Before I do a summary, I need to tell you, my publisher needs to tell me that we've written a book about this year. This is a really good book. If you want this book, email that thing. It's actually about disasters, but it's about this whole developmental psychopathology thing, and it's about type 1 and type 2 trauma, and I think it's kind of helpful. Now I really want you to heckle, so I want someone to heckle how many Tim Tams are in a packet. I think, did you say something? You said something? What did you say? She was actually, what's your name? Penny. You get a book. It's actually 11. Sorry? I know it's 11 because I come from a family of 5. Now, if you're interested in the book, go and see Penny, who's got a copy. So just to summarise, Dorothy showed us some, incredibly frightening figures about this area. It's a huge epidemic. Emotional trauma is just, incredibly common. It's actually a global epidemic, and I read a figure from a friend of mine that, there's actually 1 million babies in care in America. Okay, there's actually 1 million babies in care in America. I think this idea of type 1 and type 2 is actually very helpful. It actually helps me when I see patients, when I do case conferences, when I do supervision. I say, whoa, 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 whoa. You're suggesting a type 1 intervention for someone who's got complex trauma, or vice versa. I'm saying, well, this is complex trauma and you want to do a 6-week intervention? You know, it's actually really kind of very helpful. And clearly, to come to that understanding, you need this developmental view. You need to actually ask questions about, in fact, I start asking questions about preconception. Did you actually want this child? Okay, I actually ask preconception questions. If you're really good, you'd actually ask, what was your own experience of being parented when you were a kid? So you need to take a very good developmental history to come up with, and while I'm taking a developmental history, I'm making this type 1, type 2 graph, thinking where they are. It's really helpful for making that, it's helpful for risk, and increasingly now, you know, if you're interested, you know, follow some of the neurobiology. We're in this amazing time on the planet. There's never been a time like this before. All those gene environment tests cost me $2 in Brisbane. Okay, I can do your serotonin gene for $2. That's it. Okay. If you've paid off the CAT scan, a CAT scan costs $5. If you paid the machine off, and every CAT scan's been paid off. These are actually very simple things, and in probably 20 years, police will put you in an MRI and they'll say, did you sexually abuse the child? Because now we know some really good research that this is probably the way it's going. It's hard to lie in an MRI. So get interested in the neurobiology. It's fascinating. It's not that hard to read. Don't read the original research, read the summaries, okay? And that's all I've got to say. Thank you.